Oh, the reason why.
So I'm coming to you today from the wards of Yale New Haven Hospital. So apologize for any background noise on my side. But I'm very happy to introduce our speaker for today. Dr. Arya is a professor of medicine here at the Yale School of Medicine. He's also a professor of genetics at Yale University and is the director of the cardiac genetics program here at Yale. He's going to be talking about the genetic underpinnings of inherited cardiomyopathies. So Dr. Mani, thank you so much for taking the time, and please take it away.
Thank you so much for inviting me. It's a pleasure to actually talk to fellows and other investigators or interested people who are actually taking care of cardiovascular disease patients. This can be interactive. You can stop me at any time. And at the end, if I'm going way beyond the time, you can also stop me. So no worries there. Let me actually, everybody can hear me though?
Yep,
Yes.
you sound really good.
Okay, so I don't know what happened to the slide. Oh, because this has a, let me go to this first one. Oh, yes. Share a screen. Okay, here. So let me outline what I'm going to talk about. Do I have to stop here or no?
No, we can skip that for the interest of
Okay,
time.
skip that. I have nothing to disclose related to this talk, but let me give you kind of some overview what actually a genetic program does. It deals with actually more rare and variants. Even though both rare and common variants cause disease and contribute to cardiovascular disease, the actionable are the ones that are rare variants because they have a very large effect. And also perfectly, almost close to perfectly segregate. So, you have an autosomal dominant, you pass it on to half of the children. While the polygenic risk scoring that are being used, specifically more for right now coronary artery disease, to some smaller degree in cardiomyopathies, those are inherited from both parents and then are not going to go all passed to your children. They're going to be distributed kind of and so the children not necessarily going to have the same polygenic risk score. So we don't use that in the clinic. We use mostly rare variants, which is minimal allele frequency of less than 0.01. And that's what we are interested in. I don't know what happened here that moved. Okay. So I'm going to talk about 3 cardiomyopathies. And the reason, even though you mentioned hypertrophic and dilated, is that actually there's an overlap between dilated cardiomyopathy and arrhythmogenic cardiomyopathy now. I'm going to explain to you what we actually make how we distinguish these two and why we call one arrhythmogenic, another one dilated, even though there is a significant overlap. But hypertrophic cardiomyopathy is the cardiomyopathy that actually associated pathologically with myofibril disarray. I don't know why this slide will keep moving. Basically, there are a lot of kind of diseases that cause hypertrophy of the heart, but hypertrophic cardiomyopathy is specifically the one that has myofibril disarray, is inherited most of the time in autosomal dominant fashion, although there are in certain regions of the world where consanguinity is actually increased, they can have also recessive disease, very rare. Prevalence is actually not low, probably around 1 to 300, although 1 to 600 has been reported. And normally we become kind of aware or actually suspicious of having HCM when the thickness is more than 15 millimeter or greater than 2 z-score in children. But because we have a pretest probability of higher pretest probability among the family members, we also, if somebody has 1.3 centimeter, we think that that individual can be affected. And interestingly, only half of the patients have it by age 30, and 1/4 of the patients even have it after age 60. I don't have to go through the diagnosis. We don't have time. Only I want to say that many of the patients may not have any of these findings that you see here, or at least not detected, and only detected by the family history to have the disease. EKG is obviously kind of famous to have a pseudo-infarct pattern, but let me get to the diagnosis of the rare variants. And the reason I'm actually giving you this historic view is because you can understand why we have so much differences in kind of validity of our test, and we can say for sure one disease gene is pathogenic, another possible or kind of probable. So initially, when actually I started the genetics, we used to identify kindreds like this, affected are shown in the dark symbol, and then find the region that they share, those affected individuals share on a chromosome. And then within that region, we would have many, many, many genes. We clone them actually, tediously, and then identify the genes and find the mutation and establish the causality. Now, the issue is that the larger the family was, obviously, the higher probability that we are actually detecting the right gene. You can imagine that 4 individuals in one family can have multiple areas that they share. But they may share one region that also another family shares and another family shares. So a smaller family would make the diagnosis, or very large family could make the diagnosis. The good thing is about these kind of shared regions is that they have very rare alleles, and the rarer the allele is actually the greater the effect size as shown in this. And therefore, actually, when something has a greater effect size, is actually a great target for therapy. You guys know from ATTR that we now do CRISPR on it, or we have medical treatment for it. For CFTR, we have a Trikafta, the new drug, or PCSK9 that we actually kind of use CRISPR, or actually drugs, antibodies, or antisense oligos. So they are the best drug targets. Most successful drug targets actually come from genetic studies. The problem is that they have incomplete penetrance. So you can have one individual who is not having the disease and carries the mutation and raises a doubt that is it really the mutation or is not the mutation? So that has been a problem. But nonetheless, in hypertrophic cardiomyopathy, we have had major discoveries. And as you show here, these are the sarcomeric proteins shown in the thick filament here, which has a globular head. This is myosin, obviously, and regulated by myosin binding SSC3 here, then interacts with the actin here. And this interaction is actually initiated by calcium release and binding of troponin and movement of the tropomyosin away from the actin and allowing these to interact together. Now, 2 of these genes, myosin binding protein C3 and myosin heavy chain 7, are the most common cause in 25 and 20%. I have to mention here that myosin binding protein C3 is a regulatory protein of myosin heavy chain 7. It puts the brake on it. So you can imagine the disease can be caused by loss of function of these, becoming hyperactive or hypercontractile muscle, or gain of function of these, similarly causing hyperactivity. But as you see, there are other mutations, such as ZDIS mutations and other thin filament mutations that can cause disease. Now, there is no major difference in age or gender or family history or wall thickness or sudden cardiac death between the 2 of these. But there are some differences between the sarcomeric protein and none, such as those that regulate calcium or our ZDIS protein. So remember I told you we had families, the larger the better, or if they had multiple, the smaller families, they could have established the causality of these genes. So there are actually established disease genes, as shown here. I told you 2 of them are the most common, but there are other sarcomeric proteins, and there are myosin light chain. These are regulatory myosin chain or essential myosin light chain that are well known to be disease causing. But they are also likely, because these are discovered in a smaller family, maybe one family of 4 people. And, because they were expressed in the card and interact with the sarcomeric protein, we said, okay, very likely they do. Or they regulate calcium, such as phospholamban, etc. And those are kind of in flux. Sometimes we're going to say, actually, we don't have a strong evidence for that, for such, ZDIS protein, for example. Or sometimes we say, well, we are gaining actually more support for the causality. But when you get, as a clinician, a genetic result, they're going to tell you something is pathogenic. And when they say it's pathogenic, doesn't mean that that's the gene that is they discovered to be pathogenic, but a specific mutation within a gene, within a causal gene. What I mean with that is that very specific amino acid change or a stop codon or etc. that has been shown to be associated, that comprises a pathogenic variant. Now, likely pathogenic is that when you, for example, have a mutation that affects the same region, same codon, but it's not exactly the same amino acid change, you kind of guess that that's probably pathogenic because the very similar change has been called pathogenic. Or you get actually benign or likely benign, which because it's very common among the general population. That's how you call it benign. Now, you also get very frequently a variant of unknown significance. And that variant of unknown significance is important to be actually kind of assessed by a genetic program to see if that could be really a causal variant or not causal variant. So to do that, we normally look to see by predictive programs, is it a deleterious change based on algorithms that are used in silico? Does it affect the very important motif of the protein, which is functional part of the protein? Is it allele frequency very, very rare? If it is common, you obviously think this is not going to be causal. And then you have also cases that you have found nothing, neither a VUS nor pathogenic or likely pathogenic variant. Now, let me talk about mutation mechanism. I told you that myosin binding protein C3 puts a brake on myosin heavy chain. So therefore, most of these mutations, at least half of them, are radical mutation. When I call something radical, I mean not missense, but rather causing a stop codon or deletion, insertion, a splice variant, which is going to cause truncation of the protein. The missense variant happens in myosin binding protein C3. Some of them are founder mutations, which means that very common in the population, such as arginine to tryptophan is in 1.5 to 3% HCM patient, or valine to aspartic acid in 3.9% of the Japanese population. Mutation in myosin heavy chain 7 are mostly missense mutation, practically almost always, if they are causing hypertrophic cardiomyopathy, because it's a gain of function mutation. If you have a stop codon, you lose it. And that mutation can cause dilated cardiomyopathy. But if you're talking about hypertrophic cardiomyopathy, most of the myosin heavy chain 7 are missense mutation. Also, I have to say that sometimes your patient have more than one mutation. And those patients have generally worse prognosis if those mutations are pathogenic. And unfortunately, there are no genotype-phenotype correlation existing, meaning that you don't know if one mutation has major effect or a smaller effect or more deleterious, except for a few that I'm going to mention to you. Number one is that sarcomeric versus non-sarcomeric. Sarcomeric have a poorer prognosis. I mean, this study here, published in Heart, shows that SCD is much more common in patients with sarcomeric mutation versus those with the ZDIS mutation, calcium regulating mutation, etc. Both of them are different models, but shows more that sarcomeric proteins can be worse for having worse prognosis. And then we have a few mutations that actually occur in children, means the incidence is earlier in life. There are two of them, aspartic acid to asparagine at 239 codon and histidine for asparagine in 251. One of them causes more hypercontractility of the myosin heavy chain. And these are myosin globular heads here. I have to mention to you that you only need half of your globular head to get engaged with your actin. Actually, almost half is sequestered or not available. In one mutation, you have this having much stronger effect, hypercontractile. In the other mutation, you have also more heads available. So fewer are sequestered. They are actually engaged more with the actin. In adults, actually, they're less kind of severe. That's why they occur in adults. There are only two of them, arginine glycine and arginine cysteine at two different regions. They cause a little bit more severe disease. But this is the globular head. This is the rod. Normally, for the myosin that are not engaged, the globular head should lie on the rod, binds there should be interaction between amino acid in the globular head and the rod. And these mutation causes interaction to disappear, and the head becomes more available. So if I show you this here, this model, as you see, one of the head is not really actively available. The other one actually undergoes contraction and becomes obviously inactive. But when, and actually myosin binding protein C3 really regulates this kind of condition. And if you have a mutation, you may actually have more heads kind of engaging the actin. So as a result, if I summarize here, if you do a force measurement, the ones that actually mutations that cause hypertrophic cardiomyopathy have increased ATPase activity, increased calcium sensitivity of the troponins, and reduce myosin super relaxed state. This is the myosin that are not engaging. This is the normal, as you see here, that you have increased force generated by these mutations. Opposite is in dilated, that reduced force is generated. ATPase activity is lower. Calcium sensitivity is lower. Now, genetic testing, as I said, is done in the relatives of patients who are actually affected, or obviously the index cases. And when it's done, you do actually find, as I said, disease causing, likely pathogenic or pathogenic variant, or the VUS, likely benign or benign. But I want to tell you that that's not final. This classification is ongoing. Sometimes we actually look back and say, wow, it's actually reclassified as likely pathogenic. Or we see it so often in the general population that we say, actually, what we thought is pathogenic is no more pathogenic. But once we actually find the really causal, the benefit is that you don't need to test the rest of the family. You already have persons who actually have in the family affected. There are people who are not carrying the mutation. They're off the hook. You don't have to do serial echoes or other evaluations. So that's the good thing. The downside is actually for about 16%, we don't have any mutation identified. So we have for almost, 1/4 in some places, or here we do a whole exome sequencing. We have a little better diagnostic capabilities. So we have no diagnosis in this patient. Half have sarcomeric mutations, which I said have more worse prognosis compared to the other two. And the rest have, titin mutations that mostly occur in dilated cardiomyopathy, but also can occur in hypertrophic cardiomyopathy. Good thing is that if you don't find a mutation, identified the either family history or genetic causes, they have higher mortality compared to those who actually don't have the mutation. They have lower mortality. So that's a good thing. Another thing is that I want to tell you that in those we don't find the mutation, most likely are polygenic, multiple mutations. There was a study actually published in Nature Genetics. They did a GWAS analysis. They find fewer loci, obviously, in the genome. And they find actually some variants that they were associated with cardiomyopathy, especially in those who did not have any rare variant. Interestingly, if you on top of your rare variants, such as myosin protein C3, myosin heavy chain 7, or a specific mutation in the one locus, there was actually positive correlation. It means that you had worse prognosis if you had the rare variant and those common variants. Interestingly, when they did a Mendelian randomization, they found out that this, same loci that cause hypertension are also kind of shared with the loci that cause hypertrophic cardiomyopathy, suggesting that actually environment has a very much role in development of disease. So therefore, regulation of blood pressure based on this finding is very important in hypertrophic cardiomyopathy. For example, actually, there are many cases like these two siblings who have the same mutation, but one has hypertrophy here and the other one doesn't. So therefore, there are a lot of things that actually interfere with the effect of a mutation, from microRNAs to the other mutations that actually modify the effects, to environment, etc. Now, it is important for you to also understand that hypertrophic cardiomyopathy can also have phenocopies, means that mutations that can cause hypertrophy, but not being hypertrophic cardiomyopathy, which means they don't have myofibril disarray. They don't have that. But they have enlarged myocytes, for example. So the MPK gamma 2 non-catalytic subunit, or PRKAG2, for example, causes hypertrophy, and those patients can have WPW. The Danon disease is the lysosomal membrane protein LAMP2 that can be mutated. This one is autosomal dominant. This one is autosomal recessive. I'm sorry, this is X-linked mutation and can be actually systemic, can have effects on the heart from hypertrophy. Again, WPW similar to this one, and glycogen accumulation similar to this one in the heart. But these patients have, besides actually cardiovascular involvement, skeletal abnormalities, they have neurological findings. I'm not going to get, because of the time, to other kind of phenocopies, just mentioning that amyloidosis can do that. Also, rarely we find cases of Noonan syndrome that have hypertrophic cardiomyopathy as only manifestation without pulmonary artery stenosis, etc. Important is actually recognizing the Anderson-Fabry disease. This is the mnemonic, I don't know, which is actually Fabry, which means they have foam cells in the podocytes shown here, causing proteinuria, kidney failure, causes alpha-galactosidase A deficiency, and generally is X-linked recessive, means you have to have two alleles in woman to be having the full kind of picture. I have to say that heterozygous women have disease, so you can have some of the phenotypes mentioned here, not severe kidney disease, but some may be mild proteinuria in women who have one allele. And it is important to know that actually they have a neuropathy, which in form of burning pain, that's B of the Fabry. They have renal failure, and they can have a youth death. Important is that you recognize this disease because it has a hormonal replacement therapy. You can actually replace the alpha-galactosidase, and therefore it's important to really pay attention to a patient with systemic presentation compared to hypertrophic cardiomyopathy that doesn't have systemic presentation. So you guys know that actually now we have a new therapy. This came from genetic studies. The mavacamten actually came from genetic studies because we realized by studying those myocytes that they have hypercontractility. Therefore, this inhibitor of the ATPase, the inhibitor of myosin, was developed, which is actually a drug that we use it in obstructive disease and has some benefits that you're probably familiar, and you can hear it in another lecture. So important is to realize that the indication for AICD is not actually a genetic mutation per se, but having family history of sudden cardiac death. So if you look at the criteria, it's not a mutation that you'd, let's say, cardiomyopathy heavy chain 7 that can determine that you need AICD. But if you have one of the criteria for considering AICD is if you have a family history of sudden cardiac death. Let me jump over this and get to another advantage is that to realize that compared to ZD's protein, calcium regulating proteins, sarcomeric proteins have worse prognosis. You can do enzyme replacement therapy and galactosidase deficiency and uncovering subtle phenotype. For example, you do an echocardiogram, you don't find hypertrophy, but the patients have sudden cardiac death. And this actually has been discovered in the troponin T mutations. If you see here, that actually ventricular wall thickness has been not much increased, especially when you have a standard deviation of 4. So some patients have even normal thickness, but they have number of patients with sudden cardiac death. So that's what's the benefit of genetic testing besides cascade screening and recognizing who is affected. I realize I'm actually going kind of slow with the time. Just want to tell you that the CRISPR gene editing is at the very beginning of it for this disease, although we have this method for many other diseases. For this disease, is rare. You can do base editing, meaning that correct the mutation. And this has been done in mouse with myosin inhibition 7 mutation. Also, you can delete that region. And the reason is that you can delete that region is because it's actually a gain of function mutation. You can destroy one allele. The problem is that actually efficiencies are actually not high. And you have off-target effect. Beside that, actually, for base editing, you can only edit A and C, I mean, cytosine and adenine. I don't know why it's jumping. Adenine. And you need a specific kind of a guide RNA, which actually recognizes a region that you want to CRISPR, and PAM region, which is the region that actually your Cas editor can actually bind to, has to be very much well designed. Sometimes it's not optimal for designing the Cas system. And you can also go and delete another region or base edit another region, and that's going to be off-target effect. So we are at the beginning of that. Now, DCM actually caused by mutations in some sarcopenic proteins. I told you, for example, myosin inhibition 7, but a lot in the nuclear cytoskeleton or cytoplasmic cytoskeleton genes. There is an overlap with arrhythmogenic, and if I don't come with the time to show you all the slides, the difference is in arrhythmogenic is when the arrhythmia precedes cardiomyopathy, and that's called arrhythmogenic cardiomyopathy. A lot of genes are actually, however, very much similar. Treatment, obviously, when you have cardiomyopathy is similar. And there are actually genes that have been identified specifically for the cardiomyopathy, dilated cardiomyopathy, listed here. They are almost definite cause. And many of them, actually, desmine or filamine, they're all filamentous or cytoskeletal proteins. Shown here, actually, as you see here, this actin and myosin, but what is mutated in dilated cardiomyopathy are desmosomal proteins, for example, nuclear membrane proteins such as lamin A, which I'm going to actually emphasize on it, genes that actually regulate the splicing, such as RBM20, which is actually quite a malignant disease gene, and those actually regulating calcium, such as phospholamban, shown here. Now, again, I have to emphasize that there is a significant overlap with the genes that affect hypertrophic cardiomyopathy and dilated cardiomyopathy, arrhythmogenic cardiomyopathy. So there is significant overlap. Probably there are mutations that affects different motifs and also have gain or loss of function mutation, resulting in different traits. This was actually a patient I saw in my consult service, and as you see, it comes actually VTAC. What is interesting is actually the VT is infralateral VT, and the patient has epsilon waves. So this would be actually arrhythmogenic cardiomyopathy. The patient was having two different mutations, interestingly, desmocolin and ryanodine receptor 2. Both of them radical mutation. One is a stop codon, another one actually a splice variant. So arrhythmogenic cardiomyopathy is kind of presents with arrhythmia or conduction disease before heart failure comes. The best definition is for arrhythmogenic right ventricular dysplasia. We have the best criteria, such as RV wall motion abnormality, RV dysfunction, dilation as a major factor. You can have epsilon wave that I showed you as a major, and also embedded T waves. You can have recurrent non-sustained VT, which is if it is more than 500 in 24 hours, or sustained VT with left-bundle branch morphology. This is again a major criteria. And obviously fibrofatty replacement on the free wall also being a major criteria. The identification of pathogenic mutation is a major criteria. And the reason is that that's the part that actually is very hard to diagnose this clinically, this disease. And therefore a mutation such as desmosomal mutation can be kind of can be used as a diagnostic criteria. Not for hypertrophic cardiomyopathy. If you have a mutation, could be also kind of innocent bystander. But in this case, we use that because clinical diagnosis is difficult. Now, the first diagnosis was made in the island of Naxos where here shown here in the Greek island, and patients had very much woolly hair. Let me tell you that even in the US, I see patients who have mutations in desmosomes and have woolly hair, and they say, wow, I'm the only one in the family have woolly hair. And keratosis, another one. I told you that you have ventricular tachycardia of left bundle branch morphology or epsilon wave, and this is fatty deposition in the myocardium. All of these three are major criteria. Here shown the desmosomal proteins that actually binds two cells together. They have effect on the actually signaling pathway that I don't have time to get into, but that's how it causes disease, by altering the signaling between the two cells. And I want to tell you that now we have arrhythmogenic left ventricular disease, or you can have biventricular disease. For that, we start for actually defining if you have one or major or minor morphological criteria of RV. And then if you have one major minor criteria of LV, if you don't have it, you probably have arrhythmogenic right ventricular dysplasia, which can get classified into two kind of definite if you have two major criteria, or one major and two minor, or four minor, etc. If you have no right ventricular criteria, you can still have major structural LV criterion plus, and that is important where the mutation comes in play, that you have to have a mutation for arrhythmogenic cardiomyopathy that makes it actually a kind of a case of arrhythmogenic left ventricular cardiomyopathy. Of the mutations actually that we get, the desmosomal mutations mostly affect the right side of the heart. And the other ones, such as cytoskeletal proteins, ion channels, sarcomeric proteins, such as myosin heavy chain 7, etc., these are affecting actually left side of the heart mostly. But there is no kind of perfect rule. I want to actually kind of finish almost in one the disease mutation, which is very, very important to realize, and that is laminase C mutation. These are horrible mutations. They can cause dilated cardiomyopathy. They can even cause sudden death with a normal EF, with a 60% EF. And that can be presenting phenotype before even having cardiomyopathy. One of the hallmarks is that you have a kind of a slowing of the conduction system, which actually very much associate with the malignant BTAG and BFEB. Let me tell you that there are three criteria that are important for having higher risk if you have laminase C cardiomyopathy. And that actually, European actually, they give it a scoring. And these are the patients that they realize they need this device. One is the male sex. Another one, non-missense mutation. When I say non-missense, means that patients who have a stop codon, a splice variant, insertion, deletion. And the third criteria is EF of less than 45%. If you have all these three, male, non-missense, and less than 45, you don't have to wait to have less than 35%. These patients most likely benefit from, as many studies have shown, that they have a higher mortality if they have three risk factors. The probability of being event-free is much lower. Even two risk factors is quite high. So if I summarize, and I'm glad that I'm kind of almost finishing on time, is that all patients with primary cardiomyopathy, being hypertrophic, dilated, arrhythmogenic, should have genetic testing. And this should be done at the specialized centers, because some of these VUSs, we can make them to definite diagnosis. Well, how do we do that? Well, we bring the family members and see, we can screen them. And if these VUSs actually co-segregate with the disease, then we kind of realize that those VUSs can be really pathogenic. Patients should be also always informed of false positive, false negative, because it can happen. Patient with the pathogenic or likely pathogenic should be screened, and those are covered by insurance. Unfortunately, VUSs are not covered by insurance. So we try to find other sources to study family members who have VUS to see if they have the same mutation. Almost never covered, but if they have the phenotype, if we discover they have the phenotype, we can persuade the insurance company to pay for that. Otherwise, we have to find other sources of funding for those. Let me tell you, if the variant came as benign, don't think that it's forever benign. In 2 years, maybe become actually a rather malignant. Or if you call it actually pathological, maybe in 2 years we realize that we were wrong. Those patients who actually are phenotype positive, we didn't find any mutation for, obviously have to be clinically followed. So actually, I finish up here, and I'm ready for any other questions if the kind of group has a question.
Yeah, thank you, Arya, so much. What a great talk. I would, highly recommend all the learners on the call to kind of, when this is posted online, to go back through and take your time and read the slides. So much great information there. We did have one question in the chat, which I kind of think you kind of talked about a few different times here, including this summary slide, which is, is positive genetic testing necessary to diagnose HCM? And you kind of had mentioned phenotype positive, genotype negative patients. So maybe if you'd want to talk a little bit more about that for the audience, so in case they missed that.
Yeah. So what I probably kind of went fast over this. So there are actually about 15 to 25% we don't find any mutation. Now, it's possible we didn't know what the disease gene is in certain cases. This is going to be probably rare because almost all the sarcomeric proteins have been tested. But kind of probably 20% of patients are going to have polygenic, means that a lot of mutations in different genes that regulate calcium channels and regulate, making hyperactive actually calcium channels, and ZDIS proteins and sarcomeric proteins, et cetera, which are kind of like intronic and affect the expression levels of a gene. But with the tools that we have available now in the clinic, we don't discover them. Let me tell you, we have two different methods of discovering mutations. One is that specifically go after those genes that have been related to this disease. We call it panel testing, cardiomyopathy panels, or we do whole exome sequencing. Whole exome means that we sequence the entire encoding region of the genome, and that way we go after the mutations. So, but neither of these looks at the intronic regions. And the intronic region can have regulatory regions and places that we call enhancers, which means the transcription factor bind and regulate transcription. And those may affect the expression levels of a gene. So therefore, yes, we can have still the disease. You can even biopsy. I see fibromuscular disarray, but you don't find the rare variant. In those cases, most likely are polygenic. Did I answer the question?
Yes, I think so very well. Thank you. If there's any other questions from the group, you can go ahead and just unmute yourself.
See you later.
Otherwise, I'll just give that a moment to see if anybody chimes in. Otherwise, we'll just wrap up for the afternoon.
Arya, I had a quick question. That was an excellent talk. Thank you. This is Avi. Hi. So for this mechanism of testing every 2 to 3 years, do we have that in place at Yale, or does the referring has to send the patient back to the clinic?
You have to request it, but it's done for free. So if you have a whole exome sequencing here, we do it for free. Also, the vendors, Invitae, etc. We ask them, they have the DNA, we ask them to repeat. They also, especially, unfortunately, at Yale, we don't have this mechanism, but the vendors, the private companies, they actually report to us about the patient that they once called benign or once called malignant, and they say that this has been reclassified. So we get that information, but obviously, if you come back and you want to kind of screen your patients who had mutations 2-3 years ago, the family members for somebody who had 2-3 years ago, then it's good to actually refer them and say, is it still pathogenic? Can you look into that? Should be a screen for the same mutation, or is this become benign? And then we look at the database for you and say, oh, unfortunately, this has been reclassified as benign, and maybe we have to redo testing again in the index case or those affected, and we do it, redo testing. If it was actually a panel testing and then probably a more complete panel should be done. If it was a whole exome, then we have to look at the whole exome because the data doesn't change. We have it in the record.
Got it. Okay, this is awesome. Thank you so much.
All right. Well, thank you everybody for taking the time to join us this afternoon. And Dr. Mani, thank you so much for the presentation and the wonderful talk. Hope everybody has a great rest of your day. Bye.
Thank you so much.